Good evening and welcome to our virtual world of learning again. It just seems like for the last 3 years, we've spent so much of our lives trying to learn about COVID and understand how it fits and how do we live with it. Now we're going to have to delve into something a little bit different. We're going to have to learn about long COVID. So I guarantee you, you're going to learn a lot tonight, and all of us will be continuing to learn about COVID and long COVID probably for 5 to 10 years to come. So I'm very excited to introduce our panel tonight to help us understand this new phenomena. On my left is Dr. James McKinnell. He is an infectious disease specialist. He is board certified in internal medicine and in infectious disease. He earned his undergraduate degree from Stanford University and earned his medical degree from Columbia University Medical School. He conducted his internship and residency training at Harbor UCLA Medical Center, after which he completed a fellowship in infectious diseases at the University of Alabama at Birmingham. His clinical research focuses on epidemiology and management of chronic or resistant infections with special interest in global infectious disease issues. Having more than 15 years of diverse experience as an infectious disease and internal medicine specialist, Dr. McKinnell cooperates with many other doctors. He is an infectious disease research specialist in the Milevchik Rand Medical Group and is physician chair, Young Physicians and Professional Association. Next to him is Dr. Huynh. He is a specialist in critical care and pulmonology. Dr. Richard Huynh earned his BS in biochemistry and his master's of science in biochemistry and molecular biology at the University of California, Riverside. He traveled across the country to receive his MD at New York Medical College, after which he returned to his roots and completed his residency at Harbor UCLA Medical Center. He joined the faculty at Harbor UCLA Medical Center in general internal medicine prior to starting his pulmonology critical care fellowship at UCLA Medical Center. During his fellowship, Dr. Huynh was involved in numerous basic science and clinical research studies, earning him the 2015 American Thoracic Society Internal Conference Abstract Scholarship. And if that's not a mouthful, I don't know what is. His areas of interest include idiopathic pulmonary fibrosis and other interstitial lung diseases. Born and raised in Southern California, Dr. Huynh is an avid fan of the LA Lakers. When he's not at work, Dr. Huynh enjoys yelling at his team on TV, cooking, and traveling the world. Welcome to our panel.
Well, thank you very much for that introduction. As those of you at home are talking about spending the last 3 years learning about COVID, I think we can probably say the same.
Yeah.
So Dr. Huynh and I spent legitimately the majority of the last 3 years working together at Torrance Memorial, managing a lot of the acute cases of COVID, including those of the patients that were in the ICU and critical illness. So we spent a lot of time working together, and I think we'll spend most of this meeting today talking kind of in a conversational tone. You'll see a little bit about our banter we have in the ICU. So I think that's fair, right?
Yeah, it's pretty much a preview of what the last 3 years have been for us. So we just talk about what we thought for the entire time. Yeah.
So we're going to talk to you guys today about long COVID. And before we do, I really want to give you guys a little bit of flavor as to why COVID is different than other conditions. I think I've received research support from research grant support from Medline. I'm a research consultant for Thermo Fisher Scientific. But I think perhaps most importantly for this crowd is Torrance Memorial Medical Center has had a really active program for COVID research. Dr. Huynh and I are both investigators on multiple trials. And realistically, this is kind of the cutting edge of how we're able to treat not only acute hospitalized COVID, but long COVID. How do you bring science to win the day? And so we're really proud of the work we've done and proud of how that's come together. To give you guys a sort of sense of magnitude and sense of scope, I tend to use this slide fairly regularly. And this is the top 5 leading causes of death in the United States year over year. This particular data, I think, is from like 2017 or 2018. It was the most recent set of information I had, but realistically, these numbers don't change year over year, maybe by a few thousand up or down, but these are the top 5 leading causes of death. And if you look at COVID, the first year of COVID from 2020 to 2021, a 12-month period, COVID deaths were 583,596. In that 12-month period, it was roughly the 3rd leading cause of death in the US. And this is an important fact, to remember, right? We went through a lot of that, but to understand that COVID for us was different. It really was a completely different process. And I want to explain this in terms of numbers, and then I'll ask Dr. Huynh to jump in here, but I want you guys to think about influenza. And this is not, oh, I'm sick at home and I have the flu. This is legitimately diagnosed influenza. And if you've never had influenza, you've never had influenza. It feels like getting hit by a truck. Like you just feel terrible when you have truly confirmed influenza. And so on average, there's some variation in influenza numbers year over year. But 2019 to 2020, in the year before COVID, before we all started wearing masks and then influenza went away, 38 million infections, 400,000 hospitalizations, and 21,000 deaths. That for us was a bad viral pneumonia. We kind of knew what that was. We knew how to treat that. COVID, completely different. So again, about a 12-month window here. And you're looking at 37 million infections. So about the same as influenza the year prior. But the impact of COVID infection on a naive person, not an unintelligent person, but someone who's never had the disease, never been vaccinated, the rate of hospitalizations was 2.2 million. There's images of Central Park with triage hospitals out there, like a bomb went off. Or you look at the number of deaths, and we talked about this, 583,596. So COVID is different. It's a different process. And I want to talk to you about why. And so really what makes COVID so unique? And I'll let you kind of chime in here, but you know, there's phases of COVID infection. And so if you're able to see this at home, or those in the audience here, the early phases of COVID are what we call viral replication. This is the virus gets in your body, it hijacks your machinery, and it kind of overtakes your own body system, and it makes more virus. As a result, you trigger your immune system and you get a little sick.
I think that's, you know, in some cases that kind of reflects influenza in many ways, but what becomes different is what happens afterwards, right?
Yeah, and this is where legitimately like the rules changed. And I want to say that again, the rules actually changed. We're used to treating an infection, giving an antibiotic or giving an antiviral. In the case of influenza, you give Tamiflu. That was our treatment. It works for influenza. Ultimately, we did get some antiviral agents. But this second phase of inflammation and hypercoagulability. So what do I mean by hypercoagulability? Your body makes clots, and clots in places we don't want them. Blood flow stops in those places. It's this later phase, the inflammation and clotting, that makes COVID so different. And that really was the big change for us. And we'll talk about the viral replication phase. And I want to take a moment for you all to hear this about, you know, if you have a case of COVID and you're mild and you're not in the hospital, what are your options? How do you approach this? So the treatments we use in the hospital, remdesivir is an antiviral agent, Paxlovid is another antiviral agent, and molnupiravir. Now there's this whole other phase of passive immunity with monoclonal antibodies and convalescent plasma, I'm not going to get into that. It's a little too nerdy, if I'm honest. But if you talk about remdesivir or Paxlovid and molnupiravir, these are kind of the names you should know. How like familiar do you think your patients are with these drugs?
I think they're becoming more and more familiar as time goes on. And certainly they understand how big of a game changer having these antivirals is. And we have to understand that not only does that seemingly affect, how that acute phase pans out, but it also may have an effect on how the longer stages of COVID pan out as well. And so it's important to know that if you are unfortunate enough to get COVID-19, and you are at risk for serious illness, these medications are extremely helpful.
So I want everyone to really hold on to that. I'm actually going to review some of the science here. I want you to hear this. And remdesivir is a medication that we only use for hospitalized patients. It's an IV only medication. And what it does is it stops the virus from replicating. That whole process of viral production, it stops it cold. And the key trial, there's a bunch of them, but the key trial is the ACT-1 trial. And people get better faster with antiviral treatment and people live. Like the survival is better. So it's kind of a no-brainer medication. If you're sick, we're going to use it. Now, Paxlovid is the medication that we all prefer for outpatients. If I can use it, I will use it. That's the drug I choose to use. And the science is back there, but what I want the audience to focus on is in the EPIC-HR clinical trial, in unvaccinated results, there was a 90% reduction in hospitalization or death at 28 days. A 90% reduction is a home run. So this is the drug that we say, if we can use it, we know it works. That's a drug that we want to use. There are some limitations we can call taste disturbance. Have you heard this?
Yeah.
What's the story you get?
Everything tastes different after you take it, and that can persist for a little bit of time. It makes it difficult to eat.
I've heard this described as trash mouth. I feel like I'm eating garbage. So it's for some patients, this is a big deal. But again, you're talking about preventing hospitalization, preventing death. Like, I'm like, okay, so eat more donuts this week. Like there's a process there, but it's tricky. And then there's another like really interesting dynamic, which is in about 10% of patients, you actually get a brisk rebound phenomenon. And this is rebound not only just of the symptoms, but actually also viral rebound. And it's really complicated and we can tackle that later, but it's just something for patients to know that in about 10% of patients that get Paxlovid, about a week after completion of treatment, they'll get a full rebound. And there's drug interaction. So have you encountered this much?
Yeah, we do encounter this quite a bit, unfortunately. There are certain medications, particularly some of your cardiac medications and your cholesterol medications, some of your antiarrhythmics, some of your blood thinners that unfortunately interact with Paxlovid. And so it makes it, unfortunately, you either, for some of them, you can't take the Paxlovid. In others, you have to stop your cholesterol medications. And so that's something that if you were to be prescribed Paxlovid, make sure that your medication list is reviewed with the pharmacist. And they do a very good job of reviewing that and making sure that you understand which medications you need to hold, or if there's an interaction where you unfortunately can't take Paxlovid.
So strong plug for developing a relationship with your pharmacist. Most people go to CVS and like, oh, whoever you are, give me my medication this month. That's a terrible strategy. You really should have a relationship with your pharmacist because they can catch dosing errors. They'll look for drug interactions. That's a really key person in your clinical team. I can tell you here in the hospital setting, the pharmacy is one of my key resources here. We call them all the time.
Absolutely.
So again, you should use the tools that we use. Make friends with your pharmacist.
Yeah. Make sure your pharmacist has an updated list of all of your medications.
Yeah.
Because that helps tremendously.
So molnupiravir is kind of, I would describe this as like the also ran drug. Like it's good, but it's not as good as Paxlovid. But if I can't use Paxlovid, absolutely a really important second line agent for me. And the difference here is about, hospitalization or death was 6.8% versus 9.7%. That's about a 30% reduction and good, but not 90%, right? And there's some benefit here in terms of, does it actually save lives? So molnupiravir does appear to have a big impact on death. So that's a win, but it's not quite as potent from our sense as Paxlovid. To be honest, you can't really say that because they haven't been tested head to head. So I am comparing apples to oranges, but that's my clinical preference. I don't know if you're the same.
I agree. I think Paxlovid is my go-to for outpatients. But if you do run into troubles with, let's say, medication interactions or whatnot, then molnupiravir is definitely better than nothing.
So we talked about like how far into this road we're going to get. And I do want to talk about the antiviral treatment. You should know those medications, and we'll talk about why that's important for long COVID. But the whole sort of game-changing component of COVID is this syndrome called cytokine storm. And in 2018 and 2019, I went to some very nerdy, cool ID transplant. Like, we're going to get really dorky about this weird syndrome called cytokine release syndrome. It was the most important lecture I've been to in my career, because my entire next 2.5 years was dedicated to managing this syndrome that most of us had never heard of. Like, it was way out of left field. Had you seen this before? I mean,
Cytokine release syndrome.
yeah,
I have. It was also because I had a background in transplant in pulmonary fibrosis, and so we had to deal with it a little bit. But so that was how I was introduced to cytokine release syndrome, and thankfully I was, because it helped prepare me for the pandemic.
so if it's not clear, we're both really dorks. We're super nerds, and we like that. Like, what's kind of our thing. So we're like, oh, this is my day, right? So, but really the pediatric population uses a slightly different term, multi-system inflammatory syndrome. And really what we're talking about is you have this viral infection. And usually when you have a viral infection, your body has a response. And that response is to destroy the virus. And then that's it. With COVID, this cytokine release syndrome, or I honestly prefer cytokine storm, it sounds a little cooler, but this cytokine storm is your immune system absolutely overreacting to this virus. There's this very complex interplay of inflammatory proteins and cells, and that really creates I hesitate to use this term, but it's probably the easiest way to explain it. It's almost like your body is having an allergic reaction. That's not quite right. To be honest, that's a simplification. How does that make you, like, to me, I hesitate, but does that, I don't know how else to sort of describe it.
I think that's probably the best way to kind of describe it in terms for the community. I think that'd probably be the closest thing.
Yeah.
I like to say that your immune system's having a nervous breakdown.
That's probably fair. Yeah, you're kind of, it freaks out. It's like, what do I do? And realistically, this is what we're driving at. And, I want to give you a sense as to what this felt like. So somebody comes into the hospital, and kind of, I'm going to throw this to you. Like, how is this different?
The ramp up, I think, is the thing. The change in which the patient progresses. In other diseases, it's sort of this ramp up that we can kind of anticipate. With COVID, it literally was like a storm. I think that's such a great term to use. It's because you can go from 0 to 100 so quickly. And so patients will come in, and, at first you're looking at them, they're breathing, they're talking to you. Their oxygen levels might be a little bit low, but they feel fine. They're just coughing a little bit. And the next thing you know, they go into the storm of symptoms of low blood pressure, low oxygen, they can't breathe, they have all their heart rate goes crazy, and they just become in complete respiratory failure, and it happens at a blink of an eye. And so we really had to move so much faster than other, because it was so hard to predict. And we have patients who they'd come into the hospital, and they'd be there sitting there talking to you. Day 1, day 2, day 3, and you're saying, oh, we're doing okay, you're feeling fine, we're going to give you some more treatments, we're going to watch after you. And then day 4 comes by, and then do they just have this precipitous decline? I think that was a real big difference between what we saw with COVID in relation to any other disease that we've seen in the past.
Yeah. So I want you guys to get a sense of this, is that one of the novel approaches is all of a sudden for these patients where their immune system was going crazy, we did something that as an infectious disease doctor didn't make sense. We gave them a medication to slow their immune system down. In retrospect, it seems obvious, right? In retrospect, well, of course you should. But at the time, the idea of giving steroids to somebody with an infection, it just blew my mind. And the reality is it saved lives. And what we learned was that sometimes very aggressive immune modulation was required to shut this process down. And we would go through, here's the data from the recovery trial and the use of corticosteroids. But we got as far as giving like really serious immune suppressant medications, kind of hitting like, what are the buttons? Control, Alt, Delete to reset the computer. Like that's what I was doing to people's immune systems. I was like, stop, whatever, this will kill you. You've got to stop that. So really aggressive immune suppression in the hospital.
Well, but the timing is really important here, right?
Yeah. I'll let you tackle that one. You go for it.
Oh, thanks.
You're welcome.
So remember though, the phases of this disease, you start off with viral replication. In those times when you're in the sort of milder form stages of this disease, our immune system's working to our advantage. It's killing off the virus. It's helping slow down the replication of the virus, right? It's only once it gets into the cytokine storm phase that we're saying, oh, it's having a nervous breakdown. That's when we need to say, hey, calm down, relax, slow down, steroids. So it's really important to know that difference, because if you have mild disease and you're in that viral replication phase, and you may or may not enter that cytokine storm phase, it's not a good idea to suppress your immune system at that point in time. It's only when you're sick enough, when you're in the hospital and you're on oxygen, that's when that cytokine storm is happening. And that's when it's a good time to use those immune suppressants. It's really important there, because we do see from time to time, patients will say, hey, can I get some steroids? I heard it works really well, when, essentially they're not in that phase yet. At that time, use antivirals, remdesivir, Paxlovid, molnupiravir, your natural immune system. That's a good time for those things to be working, not to suppress those things with the steroids.
Yeah, I think I'm going to start using this nervous breakdown idea,
Yeah.
right? Like, because early in the disease, if you have this viral replication, you want your immune system to fight, right? That's what it's there for. And it's when you sort of tip over and it's dysregulated, that's when we sort of have to adjust. So yeah, good point. I like that. So hypercoagulability in COVID, this is sort of the second phase. And we are building to long COVID. We're not going to ignore you there, but you've got to understand the disease process to understand long COVID. So hypercoagulability and long COVID, and there's a bunch of different etiologies and ideas about what's causing this. So I throw two up there. One is the virus itself can damage your blood vessels, and a damaged blood vessel will actually cause clots. One part of the COVID virus is the spike protein. If y'all have heard about that, that actually can cause a part of your bloodstream to attack the edges of the blood vessel. Just like a pipe that gets a hole in the side of it, that's what causes sort of problems. That's where the vessels get jammed, is when there's damage there. Or pooling of blood, but there's a dozen other explanations.
Right. There's, they talk about how when your immune system's dysregulated, your immune system is a part of the system in which your body's supposed to create that balance between whether your blood is thin enough so that it can flow through your veins or your blood vessels nicely, or if it's, to make it thick enough so that if you did cut yourself, if you did cause some sort of injury, it creates that clot. So when you have this immune dysregulation, it alters that and you become more hypercoagulable and causes these clots to form, is another one that we hear about. There's also that, when you have COVID, it causes sort of this pooling of blood to occur. When blood is kind of stagnant, it tends to clot up. And so that also can cause hypercoagulability. So there's a lot of potential mechanisms to this, but it was something that we definitely saw very frequently in the hospital and as well as in the outpatient world.
Yeah, in the outpatient world, a lot of patients, one of the post-COVID complications was clots. We'd see people come in with DVTs or even pulmonary emboli afterwards, and strokes, even acute COVID or post-COVID. And this process is one that occurred and sort of continued on. There's a lot of data on how much of an impact this was. At least one study reported 32% of patients may have big clots in their lungs. If you look at our experience at Torrance Memorial, our rates were much, much lower. We had a little bit more of an aggressive approach to anticoagulation, which is something that we adopted here. We did see a lot of microvascular disease, so tiny clots, but this doesn't happen in other conditions.
Right.
Like the thing I want you to like reiterate here is if I compare this against influenza, like you don't see this clotting process in influenza. Like I can't imagine giving an influenza patient steroids, maybe, right? But like I didn't do it, or giving them full on blood thinning because I was worried about clots. Like we would never do that.
Certainly not to this degree.
No.
Certainly not to these numbers.
No. And so this is the unique factor of COVID. And this is why COVID causes this long syndrome.
Can we get to long COVID now, Jamie?
But I'm having fun in this part, man.
I think
We got everyone's with me so
Yeah,
far. No questions.
the
Okay.
name of the talk is long COVID.
Yeah. Okay. So the reason why we wanted to give you an introduction, an overview of the whole process of COVID is that long COVID is a product of all of that. Right. And the list of possible side effects of long COVID is really complicated. They show these crazy diagrams behind me. Fatigue is a big one. You know, pulmonary symptoms are a big one. And this is really like a multi-system complex process.
And you also see so much variability in terms of how long COVID presents itself, right? We hear about people being fatigued. We hear about people having shortness of breath. We hear about people having cough, but we also hear about people having gastrointestinal side effects, people developing IBS, people developing chronic fatigue syndrome, people developing a host of different things. And I think, you know, personally, I feel like it's because there are so many different things that can be going on with COVID and after COVID. That's why we have so much variability as to how people present with long COVID.
So I don't know if I've actually ever told you this story, but Rich and I, like I said, we've done a lot of clinical trials. And one of the things we do in clinical trials is we have to watch very carefully for side effects of medication. I had 3 patients that were in our long COVID study. We've done one where I wrote to the company and I said, I am witnessing this very bizarre side effect, and I'm going to attribute this to the medication because I have no other reason why. And it was hair loss.
Yeah.
And I was new, right? This is brand new in the epidemic. And I was like, yeah, these 3 patients who've had COVID, all of a sudden they're losing their hair. Your drug must be doing something. They all were given the placebo. So none of those patients actually had the study drug. So I was kind of scratching my head going, well, I guess COVID can make hair loss. But that's the kind of like what? Like, how do I even put that together? And one of the things that I want people to hear is that both Dr. Huynh and I feel fairly strongly here that there's real disease in long COVID. There's a real process. And we'll talk to you a little bit about what that process means and kind of our limitations of what we know and what we can offer, and kind of, you know, give those people that are listening some validation to what they're going through.
Right. So I'm gonna have to ask this apparently. Is long COVID just an infection you cannot get over?
So the definition of long COVID is, symptoms after the end of COVID. Like it's really vague because there's too many moving parts. And I'm going to kind of be very careful about this and how I describe it, because when an infectious disease doctor talks about an infection you can't get over, we're talking about you have ongoing high-grade viral replication that's likely to cause an infection in somebody else. We're really focusing on infectivity and how much virus is there, and did I kill enough of the virus? And what this graph behind me shows is that early on in the first couple of weeks of when you have symptoms, you have lots and lots of live virus that your body's producing. It's in your nose. You can give it to your neighbor. You know, I could have given it to Rich in this time period, but fortunately I don't have COVID, I hope. But this is the kind of dynamic where if I had COVID, that's how you spread it. Now, what we also know is that your COVID test will stay positive for up to weeks after you've done that test. The vast majority of that COVID testing is dead virus. Your macrophages have already digested the virus, chopped it up. It's not living. It's not able to be transmitted, but it's dead. The vast majority of people clear their virus in about 3 to 4 weeks, about the rough estimate. But there's more to it than that. Like it's not just this virus that you can't get over. It's the whole process. Do you have hypercoagulation? Do you have immune dysregulation? And kind of what's the grandfather that's kind of driving all this stuff? So where do you land in that?
Well, I think that, I always say there's a difference between having a virus that is, so I always make an analogy with shingles, right? You can get chicken pox at any age, and it can lay dormant, quote unquote, for quite some time and then represent itself as shingles later on in life. So that virus is still in your body. It's just somewhat dormant, and it's not to a state where you can pass it on from when it's not infectious, right? And I think that there may be something there where you may have I think they call it viral reservoirs, kind of areas where the virus is hiding and not really causing infectivity, but may cause long-term symptoms. On the other hand, there may be other things at play here that can be causing long COVID. For instance, we know that having COVID itself can cause a lot of inflammation in the lungs, which will lead to scarring of the lungs and what we call pulmonary fibrosis. So that might be causing one to have the symptoms of long COVID. We talked about the immune system and how COVID changes your immune system. And there's a lot of discussion about how immune dysregulation may be at play here, whether that's created by this low-grade viral process, or whether that be just because of this continued nervous breakdown that has happened from the get-go. Another thing that may be is we talked about these clots that it can occur. So we call them micro clots or microthrombosis, whether you have these tiny clots somewhere in your body that's causing you to have these symptoms. And furthermore, we know that after having any sort of illness, particularly if you were severe enough to be in hospital, or if you were critically ill, you lose a lot of muscle mass, you lose a lot of tissue, and that can also cause symptoms of fatigue, shortness of breath, etc. So there's a whole host of different things that can be causing one to have symptoms of COVID. And not to mention, there is a component potentially of psychological damage. We know in patients who are in the intensive care, they can develop something called post-intensive care syndrome, which is essentially PTSD. It mimics PTSD very much. And we know that a lot of patients long COVID will have very PTSD-like symptoms where something will trigger them, and then they'll feel short of breath, they'll feel fatigue, they'll have a cough. It brings them back to a state where they were previously. And I'm not saying that it's any one of these. It could be all of these. It could be just a few of these. I think it kind of depends on the person. I think each person may have a different manifestation of long COVID, but it's actually many potential different pathologies that are going on in that person.
Yeah, I'm really glad to hear you validate kind of the emotional impact of this. It's something that a lot of the patients that I followed would talk about, that, a lot of our ICU patients were locked in the ICU. They had limited interaction with their families. That the emotional impact on that was fairly significant. And, I don't know that I was sort of aware enough of the time to really learn how to mitigate that in those environments.
But so difficult. I mean, in terms of post-ICU syndrome, we've done so much research on it and try to figure out how we can mitigate that, how we can improve that after their hospital stay or after the disease course, and it's very difficult. Just the other day, I actually had a patient who, was explaining to me his symptoms, and he kept on remarking back as to how he lost 14 days of his life. He has a blank spot in his mind of 14 days where he has no idea what happened. And those 14 days was when he was in the hospital.
Yeah.
And it wasn't just the 14 days in which he was on a ventilator or anything like that. He was never on a ventilator. He was never on a ventilator. He was never sedated to the point where he was on a machine to breathe. He was actually breathing by himself, but he cannot remember that. And it was just because his focus was on breathing, on his illness, on trying to get better, that he cannot remember that he had been there in the hospital for 14 days, and that it triggers him every single time. And it just gives him so much overwhelming anxiety that it makes him symptomatic?
So I think if you look at the list of stuff we have behind us, there's a couple things that are unique to COVID, right? That, if I had a severe pneumonia and I was in the ICU for 14 days, maybe I would have some of the emotional trauma of that experience, or I'd be deconditioned. I'll be honest, I'm a little bit provocative here, but I would put my nickel down here on immune dysregulation. I really do think that that's the key thing that's unique to COVID, is this immune dysregulation process that occurs after the infection. Now, to be honest, that's not a proven thought. I'm very clear when I believe something, and it's kind of an opinion versus their science. And perhaps the most provocative current clinical trial that can disprove that is there's a lot of people that are studying Paxlovid, long-term use of Paxlovid, which should shut down the viral replication, to see if that will have an impact on their course. I'm super excited to see the results of those studies, but I'll talk to you guys a little bit about this immune dysregulation process and why I kind of favor that. And then hopefully Rich will poke holes in that as I go through this. But that's kind of my current working is, there's more to this immune dysregulation process. And this is a very cool study that looked at actually the immune cells in blood. And what you're looking at here, there's three groups. There's healthy volunteers in black. There's asymptomatic patients in blue, and there's symptomatic patients in red. And this is all post-COVID. And what you can see, even from me looking across the room, is that the black dots are slightly different from the blue dots, are very different from the red dots. You can see that distribution in there. And what it tells you is that the immune cells that are CD4 or CD8 are slightly different in these populations. So that to me does kind of indicate there is this ongoing immune process that is triggered. Now, admittedly, is this viral replication? I don't know. But at least this to me is kind of a key factor in the whole process. And it relates to a couple other things. And I'm going to focus a little bit on COVID cardiomyopathy. Now, this is important because when we've looked at patients with severe COVID cardiomyopathy, there's not much virus in the muscle. When they take a piece of heart, there's not much virus in the heart.
Dr. McKinnell, would you like to explain what cardiomyopathy in general is?
Yeah, the heart doesn't work.
Okay.
Yeah, sorry. I'll be simplifying. That was a good one. Yeah. So the heart isn't pumping. It's not moving blood like we would like it to. It can also cause arrhythmias and other sort of changes, but I guess calling it a broken heart is a little bit too. Yeah, sorry, I won't. So the heart isn't working. So the heart isn't working, again, not because there's so much virus in the heart that it doesn't work. And it doesn't appear to be a heart attack. It's not like there's lack of blood flow to the heart, but the entire heart looks like it's inflamed. There's all sorts of inflammatory cells in the heart muscle itself. And that appears to be what's causing the problem. Now, we can see this in that a lot of people who get admitted to the hospital have evidence that there's some heart injury going on, and this can last for months. This ongoing process of heart injury can last for months. And the VA did one of the best studies looking at the impact of COVID on your heart. They had 153,000 COVID cases. They looked at 5 million people who didn't have COVID and 5 million people who didn't have COVID from before the epidemic ever occurred. And what they're able to show is that for a year, a full 12 months after you have COVID, your risk of heart attack, arrhythmia, strokes, PEs, all of these things are much higher if you had COVID. This process keeps going and your risk factors keep going for a year. This is kind of the hardest indicator to me of like inflammation here is key. Now, I picked the heart, and that's not your specialty. There's other information here, depends how sick you are. So if you're able to avoid getting in the ICU, your risk of severe disease or this sort of long-term impact is lower. This is part of the data for why we say get on Paxlovid early to sort of prevent these more severe cases. So there is evidence here to suggest that getting treated early helps you. But I chose my organ. I picked the heart. I did give you an easy one.
Yeah.
You're a pulmonary doctor, so have at it.
So I think the thing with pulmonary long COVID is that going back from what I was saying before, there are so many different things that can be going on, right? Because symptoms that involve the lung are maybe a manifestation of many different things. So as I said before, you can get short of breath, you can have decreased exercise tolerance, you can have cough, you can have difficulty breathing because it quote unquote hurts to breathe, and you can get asthma and things like that. And we know that there are many things that can be at play here. For instance, I spoke earlier about how you can have scarring in the lungs. When the lungs are scarred, it makes it that they aren't able to fill up as well. Your lungs are supposed to be like balloons. They're supposed to stretch and take in a lot of air. Well, when they're scarred, they're not as stretchy. They're less elastic. And so when you're taking a breath, instead of being able to take in 1 or 2 liters of air, you're now only taking in about half a liter or maybe even less. And so because of that, you have a smaller gas tank. You can't get in as much air. You can't feed those organs of yours and you feel really short of breath. And particularly when you're trying to exercise, that's when you're really needing that air and you can't move it along as well. And that scarring in itself and also the inflammation oftentimes gives you that sensation that you just need a cough, right? Coughing is a natural phenomenon that we all do. It's part of our body's makeup. It is, in a sense, it's a response that your lungs or your airways in your lungs feel like something's there. It needs to get out. And there's only a couple of ways in which things can get out of your body. One is that those macrophages that Dr. McKinnell talked about can eat it up and try to, they're like the garbage men of our lungs. They kind of get rid of stuff that way. That takes a long time. Fastest way, you cough it up and out, right? And so when your lungs feel like there's something there, it's going to make you want to cough. And so it could be that the scarring on your lungs, and we know this from other diseases where you have scarring lungs, that scarring in your lungs tugs on your airways, makes you feel like there's something there, makes you want to cough. Additionally, when you have a lot of inflammation in your lungs also say, hey, there's something there. I need to make a cough. And that's why we see so many patients with this chronic cough that occur after COVID. You have this profound inflammatory response in your lungs. You have so much inflammation in there. And your body just keeps on saying, there's something there. I got to cough it up. I got to cough it up. I got to cough it up. And unfortunately, if you develop scarring, that almost doesn't leave for a long, long time. That inflammation can lead to pain while you're breathing. That inflammation, we know that with asthma is also a disease in which inflammation is occurring in your airways. It's causing your airways to tighten up and makes you wheeze and makes you cough and things like that. So that also is inflammation that can be causing that. So long story short, there are so many different avenues in which one can develop these pulmonary symptoms with long COVID. And a lot of it is because of all these things that we've just talked about. Oh, look at that.
There you go. There's your answer. He gave me the answers ahead of time.
Apparently I did. I failed to mention deconditioning, the third bullet point. I think that's really profound. I think that's a big part of this. We know anytime someone gets sick, you lose a lot of mass. I mean, anytime someone gets sick, the first thing your mom tells you is, look at you, your skin and bones. It's because you've lost a lot of muscle mass along the way. And we know how bad COVID can be. And when you're out sick for, 5, 6, 7 days with bad COVID illness, you're going to lose a lot of muscle mass during that time. And so deconditioning, you lost the muscle strength, lost the muscle mass. When you're deconditioned like that, it is quite debilitating. There was a study done, I think, back in the 70s about patients who are hospitalized. And they said that, for every week that you're in the hospital, you can lose up to 5 pounds. And I think that's really a good, accurate description. And one thing I always say is, you look at these boxers or wrestlers that try to gain 5 pounds of muscle in a short period of time, it's really difficult. And we're talking about trained athletes. So for us as non-athletes to lose a tremendous amount of muscle in a short period of time, it takes us months to get that back. And so I think that's a big component here. We talked about the immune system changes, and I touched briefly on the post-intensive care syndrome previously, but I think that's also a real thing. Patients do get sort of this PTSD like phenomenon with COVID.
So we've talked about a bunch of the different mechanisms of COVID. And if you join this lecture for us to say, oh, well, use my magic medication, it's going to fix your long COVID, I'm not going to give you that. But there are some really solid bright points from long COVID. And number one is that even when we've seen really significant disease, the vast majority of our patients don't leave with permanent lung or heart damage. We've seen some really impressive echocardiograms showing that the heart function is really diminished. But over time, 6 months, 12 months, you see tremendous remodeling of the heart and the heart recovers. You don't see that in heart attacks, right? Like if you kill muscle because you don't have blood, it doesn't heal. But with this COVID inflammatory response, you do see that. And you've seen both the serial chest CTs and pulmonary function tests. Tell me about what you see there.
Yeah, so as being part of the long COVID study, I was privy to seeing patients sort of on an interval basis over time, and we were able to look at their chest x-rays and something called a spirometry. A spirometry is basically we're looking at how well air flows in and out of your lungs. In particular, for patients shortly after having COVID, we see marked reductions in terms of their ability to get airflow in and out of the lungs. We see a lot of inflammation in those lungs. And what you see, generally speaking, is that that's just slowly improves. Now, it's not a fast pace. You know, it's glacial, if you will.
Yeah, that's a good comment.
but it does slowly improve. And I think that's something that is a bright side of long COVID.
Yeah, there are a bunch of medications that can provide some short-term symptom relief, kind of help open airways. And there's a few things that I think can help. But the last point on here is patient support groups, I think are also really valuable, either looking at forums and others. But pulmonary rehab, it's a really key comment. I think I want to let you tackle that one.
Yeah, I think I really want to bring up Joanne Bardwell here as our special guest. Because Joanne is one of our, Joanne, what's your official title?
Pulmonary rehab.
She's one of our, I think she's being modest here.
Yeah, absolutely. You get that's absolutely your seat.
She's being very modest here. She's one of our lead pulmonary rehab therapists. And, you know, she's essentially been in the trenches when it comes to long COVID. She's the one that I send my patients to say, hey, you know what, can you help them, you know, work with them, show them what exercises to do, how to reteach them how to breathe. And so, Joanne, can you share with us, you know, sort of some of your techniques as to how patients can help feel better?
Sure. Yes, I'd love to. I also would like to thank you for having me today because it is National Pulmonary Rehabilitation Week. So we're but COVID long haul, one of the things that we do and is very real, like you said, the PTSD, when we see our patients, we have a lot of empathy for them, what they've gone through, and they share their stories. The hair loss is real. And for women, it's, you know, it could be devastating. And so you have this PTSD and now you have hair loss and you're looking at different things. So what we recommend is really starting off with something simple, and that's pursed lip breathing. And what that is you're just breathing in through your nose, normal breath, and blowing out through your mouth, almost like you're cooling soup. And this does a couple of things. It helps us with our shortness of breath. It relieves stress. It makes your body relax. And your brain really can't do two things at once. So if you're concentrating on that in and out, then you're automatically going to relax your body, catch your breath. So we call them the 5 Ps, and pursed lip breathing is one of them. The second thing is to pace yourself. And the hardest thing I've seen with COVID is that when we see patients with pulmonary diseases, they, you know, have years and years.
It's the buildup, right?
It's the buildup. So
Yeah.
we slowly learn how to work our way around those. With the COVID patients, they were fine. They were fine. They went in the hospital and now they're out. They can't breathe. They have the inflammation. They're have muscle loss and muscle wasting. So they really are really in need of pacing.
Right. The amount of times that I hear patients say, but I was fine before, and I
Yeah.
want to just be back to my normal self, right? And the amount of times I hear that, and I said, well, unfortunately, it's going to take some time.
Yes,
Yeah.
it does. And so it's important to pace yourself, especially if you're getting back to exercise. The pacing is really important. You also want to plan your day. So you know that if you have a limited amount of energy, you want to prioritize and plan, right? You want to get the things done that you really need to be done and put the rest sort of on the back burner. And I always encourage people to ask for help because people don't realize that you're sick as you are. You know, they could say, oh, you had COVID. You know, how long has it been since you had COVID? 6 months. So they don't really realize how sick you are. So that's planning, prioritizing, positioning is very important as well. You want to get yourself in a relaxed position. When you're short of breath, you want to let your shoulders relax, open your, just open your chest up, do your pursed lip breathing. And it's not, doesn't have to be a big breath, especially for restrictive patients, like Dr. Huynh was saying. It's a small breath. So it's just in through your nose and out through your mouth, very gentle. So I always say like you're cooling soup off a spoon. So what does exercise look like for the long haul COVID patients? 5 minutes. And some of your 30, well, anybody that's used to exercising says 5 minutes. That's ridiculous. But it really is important to really take it slow. And because of the fact that exercise is stress on the body, you can put yourself right and back into that cytokine storm, right? The inflammation can come back. So we really want to make sure that you're exercising, really pacing yourself when you exercise.
Right. I've definitely had patients who, I talk to them, we want you to exercise a little bit, and then they just go overboard. And next thing you know, they're out for another 5 days. And during that 5 days, their body gets weaker, they get deconditioned, and it's almost, you try to go up that mountain so fast that now you've slid all the way to the bottom of it again.
And start, and then they're starting over. And of course, that's just plays havoc on the, depression and anxiety. And I think that there's an anxiety component to it all the time. With the amount of time they spent in the hospital, they're deconditioned, they're not where they want to be. So I would like just to tell people to realize that, and it's not that it's all in your head. It's not, it's anxiety. You have PTSD. And I would like to see us do a little bit better job on getting people to the right, mental health professionals would probably be nice. But so your beginning phase of exercise will be about 5 minutes, slowly working yourself up. You want to do your breathing techniques, and you can also deep breathe too. And if you look up diaphragmatic breathing, that is a nice one to do as well. So I would just start out with very slow exercise, breathing techniques, building your strength. Tai Chi is a nice one. There are Silver Sneakers. I think Silver Sneakers has YouTube videos, which are very nice and slow. A lot of them is sitting down doing cardio, so it works well. If we have the long haul program at Torrance Memorial, there are, have had a few cases where I've had to send them down to the Lundquist Harbor, the long haul COVID rehabilitation and recovery research program at Harbor UCLA. So they offer some clinical trials there, and they actually participate in their exercise program, and it's one-on-one at that time.
Well, thank you very much.
Thank
That
you
was
so much for
fantastic.
sharing.
Really
That was
appreciate you
amazing.
sharing that. That was great.
You're welcome.
And again, hooray to all of our pulmonary rehab people. They've been amazing. I mean, they've, they took on so much of the burdens of trying to help our community through COVID and the aftermath of COVID. So they've been just pushed to their limits. So we really want to thank them and all of our respiratory therapists who have been fantastic through this whole ordeal.
Yeah, I'll second that. The respiratory therapists were just a game changer in the hospital, and clearly the rehabilitation side here is a real powerful impact. There's a message of hope here. There's a message of hope that there's a whole world of cutting edge science on how to change this experience for a lot of patients. It's a massive problem, and it's a real disease. Now, we were having a conversation earlier about, being told this is all in your head is a bunch of hooey. This is a real disease. There's real inflammation that's occurring. There's real scientific evidence showing inflammation, showing damage, showing microthromboses, and it's an area of new research. There's a lot of research, not only in the treatment side of the acute side, but how to best approach the long haul syndrome and how do we tackle it. So a lot of these resources are available here. Rich is kind of my regional go-to expert on all this. So I've appreciated having him up here, and I think we're happy to take some questions if there are some.
And I do want to make sure that our panel does comment on there's another slide about the importance of vaccination. I'd like to have you guys.
Almost forgot. Thank you
comment
for
on that.
keying that one. So this is a picture I like to show, A, because my arm looks really big, but B, also because that's Matt Ostrom in the picture on the right, and I look almost as tall as he is. So I kind of like both of these pictures for this presentation. So this is worthy of comment. A bunch of questions about vaccines and long COVID. I'm not going to talk about the value of vaccines in like saving lives. We could talk about that, and it's pretty clear that's an open and shut kind of conversation. The role of vaccines for long COVID has been well studied and clearly established. I told you before that there's evidence that less severe disease results in fewer symptoms of long COVID. So what we know is that there are at least 8 large-scale, well-designed studies looking at patients that were vaccinated versus not, who got COVID. If you had the vaccine before you got COVID, your risk of long COVID was reduced by 50%. It's a really important phenomenon saying get vaccinated, A, keep yourself out of the hospital. But even if you're not in an age range where hospitalization is a big risk, long COVID is. Young folks who suffer from long COVID struggle with this. So vaccination here reduces the risk of that side effect, that outcome. There are a number of studies that have looked at the impact of vaccination after getting COVID. So I wasn't vaccinated, I got COVID. Should I get vaccinated now? And again, I'm clear when the data is a little murky. The general consensus is that getting the vaccination for COVID shortly after you've been infected may reduce your risk of long COVID. The numbers do suggest that a couple weeks, within 2 months, let's call it, of your acute infection, getting vaccinated again may reduce your risk of long COVID. This data is not as clear as the unvaccinated versus vaccinated, but some patients get worse, some patients get better, but the overall process is that patients get better. At the end of the day, looking at all of the evidence, I think fairly clearly that I would recommend if you have COVID and you haven't been vaccinated or you haven't been vaccinated in a while to get another vaccine. There is a real value to this. The science there is pretty clear.
All right. So again, we always like to look for the silver lining in anything that we go through. And I heartily agree with our speakers. I wish we understood the immune system better because I think it's at the basis of so many disease processes. Wouldn't it be nice if we learn more about the immune system because of COVID and the dysregulation that goes on to help us learn a whole bunch more about a bunch of other disease processes? And I'm a big believer that happens in medicine all the time. So we're going to dig into some questions. We'll try to get to as many as we can. Are some people at higher risk for long COVID or are genetically predisposed?
I think that for the data that we have, severity of illness, vaccination status, are probably the two biggest determinants for the risk for long COVID. Would you agree with that?
Yeah, I would. I think the impact of vaccination and how severe your disease are, those are the number one and number two factors that are kind of going to determine where you land. The unfortunate reality, though, is that some of this is random chance, right? Like it's how your body responds to that individual infection. So if your brother got long COVID, maybe your risk of long COVID is a little bit higher, but it's really hard to tease out, to be honest. So some contribution, of course, but not clear.
What are the most common lingering symptoms of long COVID?
Probably the most common is fatigue. I think that we had a slide earlier that said, I think that slide said 53%.
89% of patients had fatigue. Like it's
Fatigue, I think, is
overwhelming. Yeah.
Very quite overwhelmingly. Second would be shortness of breath, and third would be cough. But the list is quite literally a laundry list of potential symptoms.
Can COVID feel like hot flashes?
Can COVID or long COVID?
They just said COVID, but why don't we address both?
I've learned to say maybe because I can't figure COVID out, but I
That's
don't
actually
think
a good
so.
answer.
Yeah.
No, I would say that COVID can feel like anything.
Yeah.
Right. COVID can be anything. Long COVID in particular. I mean, I in my outpatient clinic, unfortunately, I see a lot of patients who come in with long COVID, and the variety of symptoms is just, it's incredible.
I would sort of say common things being common. Maybe this is a premenopausal woman. I'm going to go on a limb there and say maybe that's just menopause. So I think there is a little bit of this. How much can I ascribe to the fact that I had COVID? And this is a very slippery slope because all of a sudden everything's COVID. So, common things being common, it's probably menopause.
All right.
I don't know the case, but that's my
If
2
you fit
cents.
that
Yeah.
demographic.
If you fit that demographic, if I have
don't
hot
think I can
flashes,
tell my
yeah.
male patient that
Yeah,
he's
no,
going through
maybe not.
menopause, though.
What about hemarthrosis? We've talked about blood clots in lots of places.
I can say I haven't seen it.
I have not either.
There is an interesting
wouldn't- I
dynamic.
wouldn't-
Well, actually, I'm going to take this back because there is an interesting dynamic in this microthrombosis.
Right.
And during COVID, we saw a lot of very bizarre bleeds. We saw these retroperitoneal bleeds, which is really fancy talk for bleeds in your back. And it's kind of between where your organs are and your back. And it's this weird space that typically doesn't bleed. And all of a sudden we'd have these like big bleeds in there. And I think that has to do with that microthrombosis effect. So maybe, but I can't say that I've seen it.
That just reminded me one thing though, is that COVID is sort of a single entity, but it's not, right? We saw very different ways in which COVID presented when we went from the original COVID virus to Delta to
Fair.
Omicron.
Yeah.
So who knows, what may be going on and as the initial inciting virus, right? It could be a very different thing that we're dealing with each time.
I would say if you gave me a hemarthrosis case, common things being common, I'd be looking for the common causes of hemarthrosis.
I agree with
COVID
that.
would not be. I mean, is it possible? Maybe, but that wouldn't be where I would.
I think that's, to be honest with you, when I see patients with long COVID, one of the things that I always make sure to do is not just say, oh, this is long COVID.
Yeah.
Go do some breathing, do some exercising, etc. There are a number of different things that can be going on. So what I generally do is I take a very long history of the patient, I examine them, and then I do various testing to make sure that it's not something else that we're missing out upon. I actually had a patient who came in for long COVID and turned out that she was severely anemic and from other causes. So always look for other things first. Don't always just have your blinders on that this is just simply or not simply, I guess, long COVID.
And just for completeness, hemarthrosis would be bleeding in the joints. What are the symptoms of having clots in your lungs?
So a clot in the lung is essentially what we call pulmonary embolism. So essentially what happens is a blood clot is floated into your lungs, and it prevents that exchange of carbon dioxide and oxygen to occur. And so oxygen can't go down that path anymore. The typical symptoms, the most common symptom actually is your heart starts racing, shortness of breath. You can have a little bit of chest pain. Some patients will have a cough. Some patients have blood in their cough. Those are typically the most common symptoms that you would have that.
Is there a treatment for related eye problems? For example, focus difficulties?
So there's a lot that goes into focusing of the eyes, and there's a lot of neurologic processes that occur with COVID. There's a PAX. There's a mnemonic. There's a post-inflammatory COVID syndrome where you have very focal inflammation in different parts of the brain that can affect specific nerves. For those physicians in the room, you can almost get like a mononeuritis multiplex, where you get all sorts of individual nerves that are affected by this inflammatory process. That can absolutely happen in the eye. If you're seeing this in the eye, see an eye doctor. That is an absolute easy no-brainer. Make sure it's not glaucoma or something else. That's sort of more of the rule out common things being common, but it can certainly cause some different manifestations in those cases. It's a fairly complex, nuanced conversation that should be had with an ophthalmologist.
You have mentioned that with Paxlovid, you can get a bad taste in your mouth, and I definitely have seen that. A patient asked, can you get hair loss from Paxlovid?
I don't think that's been reported. What I do know is that COVID can cause pretty significant hair loss. So I would be much more likely to ascribe it to COVID than Paxlovid. And to be honest, that is a lesson I learned from doing clinical trials. But I think I'd be much more willing to ascribe that to COVID than the actual drug.
So I do have a question from a primary care physician. For a patient post-COVID with a history of asthma, what tests can I do or imaging to run to check for COVID inflammation or COVID side effects prior to sending to pulmonology?
Well, I think that, essentially for a primary care physician, baseline chest x-ray, I think would be a good starting point. Pulmonary function testing or spirometry would be helpful. I think that would probably be your best bet. And as with every visit, a thorough history and physical.
Chest CT?
I wouldn't go there yet. I would start with the x-ray first.
How does one get into a rehabilitation program?
A referral from your doctor, from your pulmonologist is how you would get into pulmonary rehab.
So pulmonary only, primary care?
We have our expert here. She says either
Either
one.
one.
Either one.
All right. So to my primary care folks out there, pulmonary rehab. Will my taste and smell return to the way it was before? What about my hair? Will it grow back differently than it was?
Ooh, this is a hot button one. Go ahead. I want to see your take on this one. Taste and hair.
So what the literature says is that with time, it gets back to a sense of normalcy. Now, from my experience, I've definitely had patients say, yes, I can now taste again. My hair has come back. But when it's oftentimes with it's a little different, but it's back, is how that's from my own personal experience with patients is it's back, but it is a little bit different. So there are certain things, like I've had patients who say, I love X or whatever cuisine, but now I don't enjoy it anymore. It's not as good as it used to be. So, but they have their sense of taste. They can taste all of the, and everything tastes the way it should, but it's not quite the same.
There's a description of reprogramming. The tastes are there, but they're not quite the same as before. So you kind of have to it's almost like learning a new language. You're like, oh, that's what Thai tastes like now. So there is some process that's occurred. To be honest, and from my experience, it's not common. Like usually most people's tastes just come back to normal and they're fine. But there are a number of these cases where they had this lingering process, and we get all nerdy about it because it's cool to see them kind of relearn this. But I think it's an interesting dynamic for sure.
And kind of going back to the PTSD, I never really thought that much about the taste or smell. I knew that it would affect things, but I had a woman in clinic that is a cook. And she was just devastated that when she's cooking now, she can't taste the way she used to season and to flavor. And it really had a devastating effect on her. So it does make me realize there's a lot more to the PTSD part of it, I think. Have you treated clients with dizziness and vertigo as a result of long COVID?
I've definitely had patients of dizziness and vertigo with COVID. In some cases, with time, it gets better. With physical therapy, with certain balance type activities, it improves. Some of that may be because of sort of the muscle wasting that occurs. We rely on a lot of our muscles to help with our balance, etc. And so some of that is that. I have had patients who, ended up having evaluation of their eardrum for vertigo symptoms. I've had patients who had to see neurologists with MRIs and whatnot to see what else may be going on. But yeah, we do see that. And same rules apply for the majority of patients. Over time, it improves.
Can cerebellar strokes be a result of COVID-19?
Yes, absolutely. Absolutely. That's one of those hypercoagular clot formation things. We've seen strokes in all sorts of different places in patients that honestly had no business having a stroke. So it is a real, and kind of sometimes just because of COVID, not because of any other sort of underlying syndrome. So yeah, absolutely.
Good time to plug that Torrance Memorial is a certified stroke center.
There's kind of a bit of a banter about that one, but COVID and long COVID, like especially in the deep surges of it, it felt in many ways like a war. It really did. It really feels for a lot of patients like they're having their own personal battles. And this is not a battle you go into alone. And I really, maybe I'm getting a little sentimental here, but there is a real key resource in having a community-based program that's willing to support you in that. And the expertise that the pulmonary rehab folks have, and the pulmonary team has, and our physicians have, that really is what you kind of need to plug into. And we talked about it earlier. You need to have a doctor who's going to be your friend, who's going to validate you when you're going through stuff. Helpful if they can tell you when you are being a little bit crazy, but the disease is real, and you need partners, you need friends, you need people that will help you understand the emotional side of it, the physical side of it, the anxiety side of it. It is a real challenge and a battle, I think.
I like that. The sort of, I hate to use war for analogies just because of whatever, but when COVID hit, there really was a call to arms, and this Torrance Memorial community, this network of doctors and respiratory therapists, nurses, all the way up and down the ladder, really responded. And that has persisted throughout this entire pandemic, and now into this post-pandemic phase, where we see time and again, everyone stepping up to the plate and saying, I'm going to help take care of this, and I'm going to take care of my community. So we are so fortunate to, I know for sure, I'm very fortunate to be a part of this community, and I'm fortunate to be someone who, if anything ever happened to me or my family, I know exactly where to go.
And I want to also add, I've been so impressed that the doctors that have been brought to Torrance Memorial get involved in research. Two perfectly good examples here. They're going to learn things that nobody else have learned, and it's happening right here in our community. So we have been really blessed. Is it true that taking baby aspirin can prevent heart attack and blood clots after COVID?
Oh, this is a tough one. You did the cardiac portion. This is a loaded question.
No. Don't shoot me. So what you're here, this is a pretty good banter you'd have heard us talk about. If you saw us in the ICU in the middle of whatever, talking about cases, there's a little bit of a back and forth here. And what we're talking about is the limitations of science and how do you interpret the limitations of science for someone's active question. The use of aspirin to prevent stroke is a hot button topic and the data has flip-flopped back and forth. But I'm going to sort of stick my neck out gently and say no, and then let Dr. Huynh give us the real
No,
answer.
I think that it is something that's really become up to a debate, both for stroke and with heart disease. So I feel like it's one of those things that falls into favor, falls out of favor, falls into favor. And recently it's been called into question again. So I think it's a tough answer, but at this point in time, I would probably vote the same. I'd say no.
Ongoing field of expertise or research actually is looking at anticoagulation. So this is another one where the idea of giving an aspirin is you sort of impair the platelets from aggregating to stop strokes. The other one here is the use of blood thinners to actually reduce the risk of clots in the leg or pulmonary emboli. And that data is also very wishy-washy. So when we're not sure, our oftentimes knee-jerk reaction is don't do it because we don't want to take the risk without a clear benefit. But for both of these questions, it is on a case-by-case basis. I still occasionally will give someone an extended blood thinner after they leave. It's not the common strategy, but there are cases when I see the reason why. That's kind of how I would interpret that aspirin conversation.
And I just want to be clear here. We're talking about using aspirin post-COVID to prevent these things. If you have other reasons to be on aspirin, you should definitely be on aspirin. But in terms of primary prevention, just because you have stroke COVID, I don't think that would be a good reason.
Do you know of any long COVID rehab program that addresses many issues and the long-term effects of COVID? And how do I get into that?
So again, our pulmonary rehab department has been very good at taking care of patients with long COVID. And then when the case becomes more challenging and needs one-to-one level care, then oftentimes they will place that referral over to Harbor UCLA, the rehab program there locally. I know that there are other rehab programs, in the LA County area, but predominantly I think that's where we send them.
Yes.
Cedars-Sinai also has a long COVID program that branches out into other areas. There's different facilities with active clinical research trials. And realistically, I think that's where I would push folks. If you're not getting the answer to your question, looking at the different types of clinical trials and what might fit you and trying to find the clinical trial that fits you, that's a good next strategy. So that may be all of a sudden you're going to the long COVID clinic at UC San Diego, or maybe you're going up to San Francisco or others. And those don't have to be, there's different ways to structure that, but that's where partnering with your doctor to have a better conversation about what's working and what's not is a real long win for that one.
And Cedars does have a long COVID program. The doctor, I usually have to fill out some paperwork. They require that you have a COVID test. They like the PCR. And so they're very stringent in their criteria because they're really trying to make sure that who they're involving in their program and in the studies will fit the definition. But certainly if you have any questions about that, you should be able to talk to a primary care doctor and say, am I a candidate for that type of a thing?
This is definitely one of the benefits of us having the Cedars-Sinai affiliation, that we've had this ability to easily refer patients for specialized care.
How do growing adolescents experience long COVID, and what tests should we get done for him? We're from South Africa.
I'm not a pediatrician, so that's why I scratch my chin. There are a number of things. So a growing adolescent, there's a whole range here of where a child is physically and emotionally in terms of the spectrum for how they're going to experience COVID. There are some 17-year-olds that might as well be 25 from a physiologic perspective, but might as well be 9 from an emotional perspective. So there's a lot of like, who's the patient? How do you interface with that? I think from a physiology standpoint, I talked a little bit about how CRS is linked with the pediatric multi-inflammatory system syndrome. So there is a clear, like, unifying process here that fits in. But I think more than anything else, it may be less the physiology and more the emotional toll. What we know from kids is that a lot of times kids will have COVID and it's a non-event. And a lot of that has to do with the fact that their immune system is still very different than a 45-year-old or a 70-year-old, both in terms of how effective it is at controlling the virus and how it's going to respond to these things. Not to say that there's not a similar process of long COVID in kids, it's just different. I think that the focusing in on the emotional well-being of the child through that is pretty key. Things that I'd be looking for sort of long COVID is I'd be fishing for sort of inflammatory processes. Look at a CRP, look at an IL-6, look at an IL-4, like some of the more detailed inflammatory markers. But I'm not a pediatrician, so I'm way outside my league.
This is going to be a nuanced discussion for your pediatrician, your family physician. And if it does seem like there are concerns for something like this, then I think, going to a place like CHLA or CHOC would be appropriate. I think that would make sense to me.
The question is from South Africa, and I do know there are some absolutely phenomenal infectious disease doctors in different parts of South Africa. So I think looking for the different resources in a lot of the university centers, that's where I'd probably be fishing if this were a more detailed question, as I would definitely link in with those university centers. Also reaching out to the pediatric infectious disease networks in Europe or in the US. There's a number of those that are heavily involved in this, and finding a pediatric specialist of this is probably your best answer. And if you're in South Africa, again, look internationally. In your own country, there's some phenomenal folks, but also think about where else you can look.
I'm going to lump some questions together. How do you deal with the persistent phlegm or clear mucus or lingering cough after COVID?
This is a challenge. Phlegm is really person to person dependent. A lot of it is dictated by what the consistency of your phlegm is and how easy you are able to get it out. And a lot of it is trying to, it's in you, so you have to get it out of you. But you want to do it at a convenient time, right? So for a lot of my patients, I tell them to do what we call scheduled cough events. Oftentimes patients will say that their phlegm is worse at the very early morning. So I'll have them do a scheduled cough event in the morning where they'll try to cough it out at that time. And then particularly in the evening at night before you go to bed, so that you're not awoken at nighttime coughing up the phlegm as well. With regards to the phlegm and its consistency, it makes a big difference. If it's too thick, it's harder to cough out, and so you're not able to get it out. If it's too thin, it seems like it slides up your throat and swims back down. Depending on the consistency, it will dictate what medications you would want to use. So probably the most well-known medication is Mucinex or Mucinex DM. Those can sometimes be a bit drying and can cause your phlegm to be more thick. If it's too thin, you might want to take something like that on an as-needed basis to try to thicken up the phlegm so that you can actually expectorate it. If your phlegm is too thick, which is most often the case, oftentimes it's about hydration. So making sure that you drink enough water. Sometimes I'll recommend humidifiers so that the air is more moist, it gets your phlegm to be more thin, and it helps you expectorate it better. So it's something that on a case-by-case basis, when I speak with my patients, I try to figure out what their phlegm profile is. I know I'm getting real nerdy now, what their phlegm profile is, and that will help us sort of work on how to easily effectively expectorate that phlegm.
So I really like the practicality of that answer. I mean, granted, he nerded out, like went way into like mucus consistency, like, whoa, but it's a practical, I know, but it's the practicality of it. It's the, how do I structure my day so I can actually be successful here? What are the practical tools I can have to control this, mitigate this, and get through it? And the practicality of that, that's really what experience and these experience providers really bring to the table. Is it, when he explains it, you're like, oh, that makes obvious sense, but not at the time, right? You're like, I'm coughing in the middle of dinner. How do I fix that? Well, cough before you go to dinner. Like, oh, that's a great idea. Like, these things are really cool tools. So again, talk to your great doctors.
Since we've touched upon the fact that immunization may be key to preventing long COVID, why don't you guys look into the future? Are we going to have a COVID shot every fall? Is it going to be like the flu shot? Kind of, what do you see coming down the road?
I would think so. I think that there's definitely attempts at this point in time to try to combine the influenza vaccine with the COVID vaccine. And I think that it makes sense that we would need to continue that type of practice.
So the timing of COVID vaccines is one of great debate. And I think from my perspective, I have a somewhat simplistic view of it. Patients that have been vaccinated in the last year tend not to end up in the hospital. So about 12 months. And realistically, if you haven't had your COVID vaccine in 2 years and you get COVID, like you might end up getting in the hospital. Now, the fact of the matter is that immune response from a vaccine or the infection is kind of the same. And it's a little bit better to actually get infected, but only from an immunologic standpoint. So what that means is your immune response is going to be better if you have the infection than if you get vaccinated. So realistically, if you either have the disease or get a vaccine once a year, that's probably going to keep you out of the hospital. That might not be enough to prevent long COVID, but it'll certainly help to keep you out of the hospital. Long story short, at the end of the day, I think you're talking about every fall getting a COVID shot and getting a flu shot. That's probably where we end up. It's how we're used to using flu shots. So that's probably where we go at the end of the day. It may be that we get so much circulating virus that it happens to kids, it occurs early, and sort of the long COVID and COVID syndromes kind of go away. And then maybe we ultimately get rid of the COVID vaccines because we've all seen the infection itself. But that's a rough guess on that one.
And then I'm going to ask for your crystal ball for one more thing. I have patients that, of course, think the COVID vaccine was a cause of a lot of problems. Where are we going with any research on the vaccines? Do we feel like it has been well established that they are safe?
Yeah.
So if any doctor ever stands in front of you and says, this is perfectly safe, leave. There's nothing that's perfect. I could fall off this chair and break my arm. So the idea to say something is perfectly safe is nonsense. There are clear examples of where people were given the COVID vaccine and weird things happened. There are clear cases of patients who had, because after getting the vaccine, they had impacts on their heart because like related to the vaccine. So there is some risk in anything we do. I'm not naive enough to say that. But there are two things that I want to sort of drill down on. Is number one, if you look at the number of people that had bad things happen after getting the vaccine, it was nowhere near the number of people that had bad things that happened because of COVID. Now, the little kernel of interesting truth here is that the reaction that people had to the vaccine is probably the same one they would have had when they got the virus. So the experience I had with my first real true, like, oh, you had a vaccine reaction, was a woman who got her first round of the COVID vaccine, and she noticed that she had a mild rash. It wasn't bad, but it was a pretty significant rash over her whole body. And she thought nothing of it. She said, I must have used some funny soap. Well, the second time she got the COVID vaccine, she had a huge rash. She got admitted to the hospital with like a blistering rash because of the COVID. And it went from roughly her shoulders to her mid-abdomen. And I was like, wow, that's clearly something happened. And I think the COVID vaccine was maybe the cause. So I could say, yeah, I don't know that you should ever get the COVID vaccine again. This same lady, 8 months later, actually had COVID. She got admitted to my service, and her rash went from just below her eyelids all the way down to her knees. And she peeled everything off of her body. It was horrific. She suffered from that significantly. But I am positive that if she hadn't had the vaccine, that her rash would have been much, much worse. Now, that's my honest impression of how those events played out, was that her immune response was blunted or it wasn't as bad because she had that. Now, there's all sorts of debate. If someone is really anti-vaccine, they will say, oh, well, the vaccine primed her and that's why it happened. But I don't think that's the case. I think there's clear side effects that can happen, but at the end of the day, it's a lot safer than actually having the disease.
And I think the data kind of supports that, in that you look at a lot of the things that people talk about vaccine potentially causing, and then you look at that occurring with COVID as well, you'll see that the numbers are clearly in favor of, that yes, vaccination can cause these things, but it's certainly more prevalent and far worse when you see it happen in a COVID state.
And
Yeah.
I'm going to have one more question here, and I'm going to make it a two-part question. Can you get COVID more than once? And if you can you get long COVID after each particular instance?
You can absolutely get COVID more than once. The second round of COVID tends to be less severe than the first round. That tends to be pretty common. And you can absolutely get long COVID after every round of COVID disease. I can't say it happens every time, but definitely seen it.
So I've had a patient who had COVID 4 times. And I think long COVID was the long COVID was worse on the 3rd time that they got COVID. They did not get long COVID the 2nd time they had COVID. And they had a milder form of long COVID the 1st time. And then it's to be determined about the 4th time. So you can absolutely get COVID multiple times. And I think it's luck of the draw as to how, or if, or when, or how you get long COVID afterwards.
Some of that may be the severity of the syndrome at each time. So if you're in this scenario, if the 3rd infection was worse than the 2nd, that may contribute.
Yeah.
There's also probably some of the individual variants that may cause different immune stimulation. So different variant dynamics here probably play a role. But it's very hard to predict because it's very, very rare that we actually figure out which variant a person has. We assume we know based on what the surrounding variants are, what's dominant at that time period, but it's very rare that I can say, well, you had this variant and you had that variant. I can sort of tell from the case, but not actually prove it.
Well, I know for me, I want to thank our nerds. I'm very glad that you are nerds and that you get into this stuff and that you're researching it and that you're learning it. And on top of it, you seem to care about your patients. It's not just about the science part of it. You've got that humanity. And I do think that's part of Torrance Memorial as well. So I want to thank everyone for joining us tonight. Again, food for thought, lots and lots of learning is going to happen at multiple levels over the next several years. Good night.
Thank you very much for having us.
Thank you so much. Thank you.